Hello everyone, this will be the 87th lecture on a very important topic, minimal change disease, the most common cause of nephrotic syndrome in children. I have prepared a short PowerPoint for this InstaLecture and try to highlight the key areas through this PowerPoint presentation. Now if you look at the name, minimal change disease, the word minimal is an adjective. It means very little, negligible amount of changes, which can be appreciated particularly on the light microscopy. So in light microscopy, the glomeruli mostly appear normal in this condition, and that's why this condition is known as minimal change disease. And as I mentioned, that is the most common cause of nephrotic syndrome in the children, typically seen between 1 to 7 years of age, and majority of the patients presents with features of nephrotic syndrome. It can be seen in adults, but only minority, 10 to 15% cases. So let's proceed to discuss the key points through the PowerPoint presentation. So in this PowerPoint session, we'll be mostly discussing about what is minimal change disease, which you can see here. What causes minimal change disease? Who are typically affected by minimal change disease, how to diagnose, what are the key morphological features of minimal change disease, and a brief review of the key concepts. So the name is minimal change disease. Previously, it was also known as lipoid nephrosis when it was first described in 1913, because some amount of lipid droplets can be seen in proximal renal tubules, which is a highly non-specific finding, because as this condition lipiduria occurs, lipids gets leaked out from the glomeruli. So some amount of reabsorption can occur in the tubule, and that's why the lipid droplets can be seen there. Currently, we prefer the term MCD, minimal change disease, and we try to understand why minimal change disease occurs, who particularly gets affected by disease, how the patients present, and what are the key morphological features and diagnosis, and at the end, the brief review. The first big concept about minimal change disease is this, that it's an example of podocytopathy. It's an example of podocytopathy. That's you need to keep in mind. Because through some glomerular permeability factor, particularly nowadays I think some cytokine, most well-known cytokine for this is interleukin 13, that causes some amount of injury in the podocytes and also causes alteration in the glomerular basement membrane, particularly in the charges. And that all those things actually results in the formation of minimal change disease. The very big concept about this, that minimal change disease is not characterized by immune deposits. Rather, some circulating permeability factor, particularly some cytokines, thought to cause some damage to the podocyte and also some changes in the basement membrane, glomerular basement membrane. But unlike other causes of nephrotic syndrome in the adult particularly, like membranous nephropathy. Membranous nephropathy is a cause of nephrotic syndrome and it is characterized by immune deposits. But in this condition, we don't see any immune deposits as such. It's a major cause of nephrotic syndrome in the children, as I told you, most commonly seen between 1 to 7 years of age. 10 to 15% cases can be seen in adults. And in adults after 8 years, we see some cases of nephrotic syndrome due to minimal change disease. But in adults, you need to rule out the more common causes of nephrotic syndrome, like focal segmental glomerulosclerosis, FSGS, focal segmental glomerulosclerosis, and membranous nephropathy, MN. So, as I already mentioned, that minority occur in adults, but predominantly, if a child is presenting with nephrotic syndrome, you need to rule out minimal change disease first. Ethnicity also matters. Most of the cases are seen among the Asians and Caucasians. And another important association is with hematologic malignancies, particularly the lymphoma, Hodgkin lymphoma. It is seen more frequently in patients with Hodgkin lymphoma compared to normal population. So obviously, when you are getting a patient of minimal change disease, please try to do the lymph node evaluation, particularly in the axillary cervical lymph node region, because there may be a coexistent Hodgkin lymphoma you should not want to miss. And also it is also associated with leukemias and non-Hodgkin lymphoma. And there is also association being reported with solid cancer, solid malignancies, but it's very rare. The most important cancer that you need to rule out coexistent with this is Hodgkin lymphoma. Another important point is that this is also common in person with atopy or allergic disorders. So this could be a coexistent thing, that atopy or allergic disorders might be present in the patients of minimal change disease. Morphologic fracture, as the name implies, minimal change is seen in the light microscopy, basically on glomeruli, because it's a glomerular disorder. Nephrotic syndrome is a manifestation of glomerular damage. So this disease, the glomeruli, appears normal, apparently normal on light microscopy. Because in glomerular disorder, we usually do three things. One is light microscopy evaluation, another is immunofluorescence evaluation, another is electron microscopy evaluation. And as I mentioned, that electron microscopy is actually done for diagnosis in this condition, glomerular disorder. It's not for research purpose, as many people think, due to the lack of exposure. Electron microscopy is many times required for the diagnosis of glomerular disorders. Diagnosis, it's important. So on light microscopy, glomeruli appear normal in these diseases. And usually in immunofluorescence, we don't get any immune complex deposit. Immunofluorescence becomes negative in this condition. But in electron microscopy, we can see the diffuse effacement, or also described fusion of food processes. But here I need to keep in mind that two things, that what is meant by the effacement, diffuse effacement of the food process. It basically means that cytoplasm of podocytes appear flattened over the external aspect of the glomerular basement membrane. If you look at the image, you definitely understand what I try to mean. Another thing I like to highlight here, that these diffuse effacement food process of podocytes is not unique for this condition. It is also seen in other causes of nephrotic syndrome, like FSGS, membranous nephropathy. But in membranous nephropathy and FSGS, we also get other features. That means, for example, in membranous nephropathy, you can get subepithelial deposits, the presence. In focal segmental glomerulosclerosis, we'll be getting a lot of changes, particularly the sclerosis formation, focally glomerular, less than 50% glomeruli with partial sclerosis. But if this is the only change, that your light microscopy appear normal, immunofluorescence is negative, but this is the only change, that diffuse effacement of food process of the podocytes, then only you need to think about this. Now, here comes one key concept, that do we require biopsy diagnosis in minimal change disease in all cases? Answer is, if it is happening in the children, and as in the children mostly they are steroid responsive, that's not required. But in adults, as you need to rule out the other common causes of nephrotic syndrome like FSGS and membranous nephropathy, you need to perform biopsy. But if the child is promptly responsive by steroids, you do not require biopsy, because mostly they would respond to the steroids, short course of steroids. Now, another thing is that what is basically meant by this diffuse effacement of food process? What are the changes which are specifically seen? You can, more specifically, the changes which you see on podocytes are retraction, widening, and shortening of the food process of podocytes. Here, if you see that this is the left side is normal, and the right side, if you see that there's some microvillus projections are seen over the podocytes, and the podocytes usually appear flattened over the external aspect of the glomerular basement membrane. This is meant by the term food process effacement. Pathogenesis, why it occurs? Well, we don't know 100%, but what is thought that there's a T cell dysfunction is associated with this. And this T cell dysfunction results in some glomerular permeability factor, which causes some damage to the podocyte. Particularly, they think about the role of interleukin 13. Interleukin 13 has been seen to be overexpressed in the patient who is actually having relapses. Interleukin 13 overexpression in animal models has also shown same kind of presentation which is seen in minimal change disease. So a very pivotal role of interleukin 13 is thought to be behind this minimal change disease, but no one knows for 100% for sure what actually causes minimal change disease. Now, another key concept that you need to understand, that normally the glomerular basement membrane is negatively charged. And that's why when negatively charged proteins, they try to come closer to the basement membrane, they get actually repelled from each other. And that's why they usually don't leak. And these electronegative charges of the basement membrane, they're provided by sialic acid and heparin sulfate. Now, as I mentioned already, in a normal circumstance, in a normal person like you and me, the negative charge of the GBM, glomerular basement membrane, causes repulsion of the circulating albumin molecules. So albumin molecules usually do not leak out because albumin is negatively charged at neutral pH. So negative things causes negative repulsion of the negative, another negative thing. So albumins usually, when they come closer to the glomerular basement membrane, they get repelled and they usually do not leak out via the glomerular basement membrane. So they stay inside our body. But there is an alteration in the charge of the glomerular basement occur in this condition. And this extensive food process fusion appears to be due to epithelial injury, and there is some loss of the negative charge, anionic charge of the glomerular basement membrane is seen, which results in the proteinuria. So the degree of podocyte, this is another finding they have seen actually, that the degree of podocyte food process effacement does not correlate with the degree of the proteinuria. This is another interesting finding has been found by the studies done by researchers in the Amsterdam University in the Netherlands. But they have not found any direct relationship between the podocyte food process effacement with the degree of the proteinuria. But obviously it has a causative factor. It responds well to treatment with corticosteroids, as I mentioned. And corticosteroids, usually, most of the cases, short course of corticosteroids would remit or causes actually relieving of the features of the patient. But some patients, the proteinuria and other things could come back. So, in a brief, what we learned in this session that glomerulus is basically a sieve which acts like a filter. Glomerulus is the basic filtering unit of the nephron, and that glomerular filtration barrier has endothelial cell, glomerular basement membrane, and podocyte. Podocytes are food processes, the intercellular junctions, they play a crucial role. Minimal chain disease is thought to be a particular podocytopathy, where podocytes somehow get damaged by some circulating factor, which is associated with T cell dysfunction. Particularly, there's a role of interleukin 13. There's also some changes associated in the negative charge of the glomerular basement membrane. The net effect is there is a massive proteinuria, and that results in hypoalbuminemia. In this condition, also selective proteinuria occurs, means only the low molecular weight charge albumin gets leaked out, and other features also develop. More common in the children 1 to 7 years, so association with hematologic cancers, particularly the Hodgkin lymphoma. Light microscopic glomeruli appear normal. Immunofluorescence are negative, no deposits seen. And electron microscopy, there is a diffuse effacement of the food processes seen. I already discussed about these things, and they are usually corticosteroid responsive. So these are the key concepts that you need to know about the minimal chain disease. As I progress in discussion with other causes, I will also compare and contrast minimal chain disease with the other diseases. So that's all for the key concepts that you need to know about this minimal chain disease. Thank you very much.